Good afternoon or good morning from wherever you're logging in today. I'd like to welcome and thank everyone for joining us for today's webinar, Empowering Healthcare and Social Service Professionals, New Clinical Guidelines on Social Isolation and Loneliness in Older Adults. This webinar is being hosted by the Canadian Coalition for Seniors Mental Health, which I'll be referring to as the CCSMH going forward. My name is Betty Watson-Borg, and I will be your moderator for today's 60-minute webinar. I will be joined by Claire Checklin, our CCSMH Executive Director, for some opening words, followed by Dr. David Conn, Co-chair of CCSMH, Principal Investigator of these guidelines, and presenter for this webinar. Team members Lisa Tinley and John Saunders will be supporting our Q&A and any related technology. The chat will be on for the first couple minutes in case you have any technical questions. Before we get started, I would like to take a moment to share our land acknowledgement. We recognize that the work to develop these guidelines takes place on many Indigenous territories, including the traditional and ancestral homelands of First Nations, Inuit, and Métis peoples. These territories may be under treaty, unceded, or contested. We're committed to advancing reconciliation and equitable health outcomes for all Indigenous people. A few housekeeping items before we get started. Our webinar today will take the format of a 30-minute presentation, 35-minute presentation of the CCSMH Clinical Practice Guidelines on social isolation and loneliness in older adults. So that we're hoping that this will provide an opportunity for you to become familiar with the contextual and societal environment around this topic, as well as the guideline development process and the recommendations contained in these guidelines. And then we're hoping that we'll have 10 to 15 minutes for Q&A to follow the presentation. And just to mention that at the end of the webinar today, there will be a short feedback poll that we're hoping that you'll take a couple moments to share some feedback about this webinar, as we really, really value your input. We are thrilled that we are over 1,000 people registered for this webinar today. And to note that it will be recorded, we are recording, and that this recording will be available on our website within the next week. So thank you everybody for registering. We're thrilled to have you here with us. I'd now like to introduce our Executive Director of CCSMH, Claire Checklin, for a few opening words.
Hi, everyone. Thank you all for joining us today for a presentation on Canada and possibly the world's first ever clinical guidelines on the prevention, assessment, and interventions for social isolation and loneliness among older adults. Some of you likely know that the CCSMH is not new to developing clinical guidelines on mental health issues that affect older adults. But developing guidelines on this issue was very different for us. And it was a different sort of challenge, but it was absolutely well worth taking on. I'm confident that the guidelines that you'll be hearing about today will help you further frame the issues of isolation and loneliness in your work and in your practices, and will give you some needed guidance to help you support clients and each other moving forward. The launch of these guidelines today and this week is just the beginning. We're looking forward to continuing to work with and learn from all of you and your colleagues and your organizations as we look ahead to bringing these guidelines to life at the individual, organizational, and systems levels. So thanks again for attending today, and thanks also to our wonderful project funder and to our fantastic national guidelines working groups, to our external reviewers, and to the project staff, and to each and every one of you for all that you do. With that, I'll pass you back to Betty.
Thanks very much, Claire, for opening up our session today and for your unflagging leadership to CCSMH. It's now my pleasure to introduce our presenter, Dr. David Conn. Dr. Conn is the Executive Vice President of Education and Chief Academic Officer at the Baycrest Academy for Research and Education. He is a professor in the Department of Psychiatry at the University of Toronto and a geriatric psychiatrist at Baycrest, also in Toronto. Dr. Conn is a founding co-chair of the Canadian Coalition for Seniors Mental Health and past president of the Canadian Academy of Geriatric Psychiatry. He's also the author and or co-author of more than 100 publications and has received numerous awards, including the Canadian Academy of Geriatric Psychiatry Award for Outstanding Contributions to Geriatric Psychiatry in Canada, and on the national scene, a Distinguished Service Award from the International Psychogeriatric Association. We are so fortunate to have the commitment, leadership, and passion for this topic from Dr. Conn. So please join me in welcoming him here for this presentation today. Welcome, David.
Thank you so much, Betty and Claire, and hello, everyone. I'm thrilled and delighted to be able to speak to so many of you today from across the country, and I'll start with disclosures. So I don't have any specific conflicts of interest related to this presentation. I do have some grant funding from a number of agencies, as you see there. I've received an honorarium for my work on the working group for this project. None of the working group members declared any conflicts of interest, and this guidelines project has been made possible through the generous philanthropic support of an anonymous foundation. So the learning objectives for today. So I'm hoping that by the end of this presentation, you'll be able to list some of the risk factors and negative health impacts associated with social isolation and loneliness, to be aware of the main recommendations from the new clinical guidelines, and to be able to reflect on how you can assess factors that contribute to this problem and then recommend appropriate interventions for your patients and clients. Just one moment about CCSMH. So seeing as so many of you are with us today, we'd encourage you to, if you haven't already, if you'd like to join CCSMH as an affiliate member, it's completely free. All you have to do is go onto our website where you'll find many resources and sign on. So we'd love to have you on board. CCSMH is now about to become 22 years old. And we are linked to the Canadian Academy of Geriatric Psychiatry. So let's start by defining social isolation and loneliness. So they are overlapping concepts, of course, but they're different. So social isolation is an objective measure. It's a measurable deficiency in the number of social relationships that a person has. So it can be measured. Loneliness, on the other hand, is much more subjective. So it's an internal, subjective experience of feeling. It's an unpleasant or painful sensation felt when a person's social relationships are lacking in quality or quantity compared to what they desire. So, of course, social isolation can increase your risk of loneliness, but more social contact does not automatically reduce loneliness. It's the quality of social relations that are important. So some people have talked about social isolation and loneliness as an emerging geriatric giant. Geriatric giant refers to, some of the major issues that older people face. And many of you know that in the United Kingdom, they announced a minister of loneliness in 2018. And there's been a campaign to end loneliness that's over 10 years old. Other countries have also declared national strategies, such as Australia, Japan, the Netherlands, and the United States. And the World Health Organization has named social isolation and loneliness as a growing public health and policy concern, and just a few months ago announced a WHO commission on social connectedness. So various surveys find high rates of Canadians reporting being isolated, lonely, or both. This was from a few years ago, 48%. That's pretty high, isn't it? This is the US Surgeon General, Vivek Murthy, who's been a real proponent on this issue and actually recently took up co-chair of this new World Health Organization commission. But he said that we live in the most technologically connected age in the history of civilization, and yet the rates of loneliness have doubled since the 1980s. There's already been a lot of work done in this area, and this is just a sample of some excellent documents. If you want to read more about this, these are all really helpful. And it includes the document on the left from Canada's National Institute on Aging, a document from the National Academy of Sciences, Engineering, and Medicine in the US, focusing on opportunities for the healthcare system, but very, very relevant for us in these guidelines. Then the US Surgeon General's report just last year, really saying this is an epidemic and we need a whole new approach to handle this. And then a document from the UK campaign on promising approaches. So when we think about the prevalence of loneliness, you'll see lots of different data. It depends on how you sample the population, what instruments you use to measure social isolation and loneliness. But this gives you some idea. So this actually gives you data from 3 different time points, and it's from the Canadian Longitudinal Study on Aging. And what you see there is a big jump in 2020 during the pandemic, during the COVID pandemic. No surprise there. And you'll see that there are higher rates for loneliness among women than men. That's a common finding. You might ask, how does Canada compare to other countries? We actually don't do very well. In fact, a Commonwealth Fund report looking at 11 higher income countries in 2021 found that we were the most lonely of those 11 countries. And that was looking at older adults. Well, a lot's been written about loneliness, but I think this is quite fascinating. So this is a quote, or several quotes, from a German-American psychiatrist by the name of Frieda Fromm-Reichmann. She said, and this is back in 1959, she said that there is a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject. Thus, it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. She goes on to say that loneliness seems to be such a painful, frightening experience that people will do practically everything to avoid it. So I put up a quiz question here for you to answer for yourself. Question is loneliness included as a criterion for any mental disorder in the DSM-5? The DSM-5 is our diagnostic manual. It's kind of the Bible of mental illness. And so the question is really yes or no. And I'll put up the answer now. Whoops, went too far ahead. But yes, it turns out that in the 1,050 pages of the DSM, loneliness is mentioned only once. And the place that it's mentioned makes sense. It's one of 8 criteria within an item for prolonged grief disorder. So this is a period of grief that goes on beyond a year, and that's very severe. And it talks about intense loneliness as one of the potential criteria for this. I think most of you are probably aware of this, that there's this strong association between isolation and loneliness and poor health. And you'll see these numbers. These come from the NIA document that I mentioned earlier. But look at these numbers, and they're really dramatic. So huge increase in risk of stroke, coronary heart disease, and cancer, increased risk of developing dementia, increased risk of functional decline, and indeed an increased risk of death. And of course, there's also a strong association with mental health problems, including depression and anxiety. How could this be possible? How could there be this strong association? And this figure attempts to explain it. And it's obviously multifactorial. But the idea here is that if you're socially isolated and lonely, you're more likely to have a poor, an unhealthy lifestyle. that there's a variety of psychological aspects to this, including depression, and depression itself is associated with very poor morbidity or outcomes, including an increased risk of death. That actual adherence to treatment and getting a treatment for underlying health problems is poor, and that all of these things can conspire actually to change our body in ways that are unhealthy, such as by increasing inflammation, stress, all of the things that we know are negative, and that can make us ultimately more liable to become ill and even to die. And this is summarized by Julianne Lundstad and a colleague in the New England Journal of Medicine last year, who said, and I'll read this: social isolation and loneliness are rarely listed on a death certificate, yet they may have contributed to the excess deaths from all causes observed during the pandemic. And although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. They go on to say, patients' lives may hang in the balance. That's strong stuff, isn't it? It's quite dramatic saying this. And this is one reason for us developing guidelines and feeling that this is a really critical and vital step to take. One more quote. This comes from Amy Friedman and Jennifer Nicole in an article recently, pointing out that family physicians and other primary care providers might be the only point of social contact for many older patients, and that the primary care sector has potentially a huge role to play in trying to solve this problem or make things better. Amy, by the way, Amy Friedman is one of our working group members. So that brings us to the guidelines. So clinical practice guidelines, the main objective was to develop practical evidence-based guidelines in the prevention, screening, assessment, and intervention regarding social isolation and loneliness among older adults, of course. And our target audience is, the primary audience is healthcare and social service professionals, but we also believe that older adults, their families and care partners, policymakers and administrators will be interested and will find these guidelines helpful and important. So I'm speaking on behalf of our working group members and our team at large. So, but this is our team, our fantastic, extraordinary team who all worked incredibly hard to put these guidelines together. So I'm incredibly grateful to all of them. And as you can see, they're an interprofessional, interdisciplinary group from coast to coast, from Newfoundland to British Columbia. And also many thanks to our expert reviewer group, to our research associates, Jeanette and Celinda, and of course to our fantastic CCSMH staff. You've met Claire and Betty, John and Lisa are on board as well. I also want to thank everybody who contributed to 2 surveys that we carried out that were incredibly informative for us as we were developing the guidelines. The first was a survey of healthcare and social service professionals, more than 300 responded, and then a survey of older adults, more than 2,000 responded, and this really helped us. Let me mention the recommendations themselves are given a grade based on certainty of evidence, which we characterize as either low, moderate, or high. And that leads to then a strength of recommendation, which is either strong or weak. But using the grade methodology, the strength of recommendation is not simply based on the certainty of evidence. It's based on other factors, in particular, the balance between the benefits and the risks. Fortunately, the interventions that we recommend don't have a lot of risks. They have lots of potential benefits. And because of that, you'll see that for many of our recommendations, for most of them, it's actually a strong recommendation that we make. We also have a separate category that we call consensus, and that's for areas that really, where the recommendations are not based on empirical research evidence, but rather on the consensus of the expert working group. So as always, one starts with a literature review, and we started with a rapid integrated scoping review, followed by further focused literature searches. This was the first stage, looking at academic and grey literature, Canadian international publications. We were looking primarily for either meta-analyses, and there were very few of those, or systematic reviews that would help us in the initial stages of this. And eventually, through an intensive search, we found 71 relevant documents and 38 reviews. What we did find was that the research generally on interventions is highly inconsistent regarding methods, outcomes, settings, delivery mode, etc. So, overall, the level of evidence is sort of low to moderate. When developing guidelines, usually you look for existing guidelines as a first step, and we were unable to identify any existing clinical guidelines. As we were doing this review, though, we were very fortunate in that one of our working group members, Peter Huang, was just about to publish this, which was a meta-analysis, a first-rate, high-quality meta-analysis of interventions for older adults. And of course, this was extremely helpful for us. It was published shortly after we started our search in JAMA Network Open. And he was working with a group from the University of Calgary, primarily from the University of Calgary. And their systematic review and meta-analysis included 70 studies from 1985 to 2020 and randomized clinical trials of adults aged 65 and over that used a validated quantitative outcome measure. And they did a loneliness meta-analysis of 44 studies. There were multiple types of interventions, with most having a small effect size. Interestingly, the largest effect sizes were actually for animal therapy and video conferencing in long-term care. So now we come to the recommendations. We divide them up to prevention, screening, assessment, and interventions themselves. So the first recommendation is regarding risk factors. So I'm just going to use the term professionals rather than reading healthcare and social service professionals, but we were very deliberate in these guidelines not to just say healthcare professionals, because we know that professionals and individuals working in the community are a vital part of the ecosystem that can help this problem. And it's a combined effort. And so, but I would just use the term professionals or providers going forward. We say that it's important for professionals to have knowledge of major risk factors for social isolation and loneliness, to identify older adults who may be socially isolated or lonely, but also to anticipate any possible changes in their life circumstances that could put them at risk of social isolation and loneliness. And this is a list of risk factors associated with social isolation and loneliness. And I'm not going to read through them. You can see them, but it's a pretty long list, as you can see. When we think about prevention, major life transitions are really critical, of course, and that's something that might be, in some cases, anticipated. And I'm going to move on now to the next recommendation, which is regarding education and training. So we say that this is a vital topic for curricula, for healthcare and social service students, as well as practicing professionals. We also say that we should use our role as agents of change to help inform and educate patients, clients, and the general public about this association between social isolation and loneliness and poor mental and physical health, and to promote social connection. Screening. So The recommendation is that we should use targeted screening for those older adults who have risk factors for social isolation and loneliness. Now, I want to note that stigma is an issue, and some people may be less open to discussing loneliness or being labeled as lonely, and that certainly came through in our survey. Some people said that they would not want to talk about this with their doctor or other healthcare provider. So we should bear that in mind. We go on to say that when screening, we should use evidence-based screening tools to identify patients, clients who are socially isolated and or lonely, to assess the severity of the problem, and to use in routine follow-up. So the pearl here is that it's important for us to respect the highly variable need for social connection and the value of some degree of solitude. So solitude often gets left out of this discussion, but I think it's important to note that virtually all of us enjoy a certain amount of time being on our own and get something out of that. And but it's highly variable. And so it's very important to respect that. And not to just say everyone needs to be as socially connected as possible. People are very varied in regard to this. When it comes to using screening tools themselves, we do recommend some. This is the list of tools that we recommend. They vary in length. Some are focused more on loneliness, some are more on social isolation. The CARET tool is an interesting one. It was developed by Nancy Newell, a member of our panel, along with Verena Menek in Manitoba. And it actually looks at both social isolation and loneliness. It's a very practical tool as well. So it's definitely worth looking at. Inside the document, the full guideline document, which you can download, all of these scales are listed with the exact questions to use. I'll just put up the two briefest. One is a single item. That's very attractive for busy clinicians. It's just during the past week, how often have you felt lonely? Another question I think one might ask is just, do you ever feel lonely? One question I have for you is, how often do you actually ask your patients, your clients, if they feel lonely? And I actually asked myself that. And as we've been progressing with this project, I find myself actually asking my patients more often about this specific question and realize that it's not a question I've always asked in the past. And it's easy to make assumptions and to be wrong, in fact. And I've had patients who I would have thought would tell me they're terribly lonely. They've been very isolated during the pandemic. And some will tell me, no, they're not actually lonely. So it's very interesting. One of the most commonly used tools is the UCLA loneliness scale. This is the 3-item version. There are a whole variety of versions of this scale, but this is the 3 items. So just those 3 questions that you can see there. One thing you'll notice is that it doesn't actually ask if the person is lonely. Isn't that interesting? And yet it's the most widely used loneliness scale in the world. We do recommend that documentation is important. So we say this should be documented in the health record. And we say that it's an important social determinant of health and that it should be considered a psychosocial vital sign. So assessment. Not surprisingly, we recommend a thorough clinical assessment with a patient who is socially isolated and or lonely to explore the possible causes and identify any underlying health conditions that may be contributing factors. We suggest that using a biopsychosocial approach is optimal and that through a comprehensive assessment, you can come up with an appropriate management plan. We do acknowledge that assessment may vary according to your scope of practice. So these are some key components, though, in the assessment. So obviously, it's important to look at medical history, social history, mental health, cognition, screening for substance use, looking at the environment and finances, recent life events, lifestyle, and then insight and motivation for change. Although that's at the bottom of the list, it's pretty critical if you think about it. We also say in our guidelines that utilizing a strengths-based approach can help identify an individual's positive attributes and protective factors while avoiding stigmatization that can result from deficit language, ageism, images of dependency, etc. So even though we're looking, at a typical assessment, it's also important to look at a person's strengths. So when it comes to interventions, first we start with the overall approach. So what we say is that it's important to ensure initially or concurrently that treatment is provided for any underlying medical conditions identified in your assessment, to take an individualized approach with shared decision-making. And I think that this is one of the main messages. There's certainly no single answer or single intervention. And of course, that's obvious, but we do really want to emphasize that. And it's important to identify an individual's interests to determine what interventions may be the best fit, while at the same time looking at individual environmental resources, and a need to recognize the diversity within older adult populations. Very, very important indeed. Then we have the list of all of the different types of interventions that you might consider. And we say that they should all be considered because it just depends on the individual in terms of what is the best approach. So we say that no conclusive recommendations could be made for certain types of interventions over others when we look at the evidence. One thing we do say is that there's no treatment for isolation and loneliness, no pharmacological treatment, except if you're treating an underlying disorder like depression or hearing loss. It's also important to note that there's some overlap between our intervention categories, and that was inevitable. So let's go through the interventions. So the first one is social prescribing. We go into some detail in terms of the actual recommendations. This is a summary. But what is social prescribing? Essentially, it's where the health sector makes recommendations regarding social changes through linkages to the community and community resources. There are different models of social prescribing, and I think there's a range of different approaches, but it is an approach that's gathering steam and resources, and we think that it's an excellent approach that needs to be carefully considered, bearing in mind that the amount of resource available is going to vary dramatically from community to community. And the optimal models of social prescribing involve having extra staff who can be involved in the step of connecting people to resources. So they are sometimes called link workers or system navigators. And there are organizations who've managed to actually hire people for these roles. So a family doctor or other healthcare provider could make a referral to a link worker who could then link the person to the optimal resources in the community. So we think this is a great approach. We now have a Canadian Institute for Social Prescribing, and this is an exciting development, which started out in the United Kingdom. So we say that organizations should consider developing social prescribing strategies or teams, and that community organizations should consider developing relationships or partnerships with clinical organizations. There's an overlap here, of course, but the recommendation here is that we should support, encourage, and empower individuals to engage at their optimal level of social activity. Note, optimal level. It varies from person to person. you know, there's a whole variety of social activities to consider here, whether it's volunteering or intergenerational programs or befriending programs, attending senior centers, attending religious services, a long, long list. So it's not like we can say one's better than the other. It's a matter of finding the right social activity for the person who you're working with. Now, we also recommend physical activity. Of course, physical activity is good for just about everything related to health, whether it's brain health, heart health, depression, you name it. Physical activity is good. But interestingly enough, there's also evidence that physical activity can help loneliness and social isolation. Studies demonstrate this. Interestingly enough, you'd think it would have to be in a group for it to help, but it doesn't have to be in a group. So individual physical activity can also help. We don't recommend a specific form of physical activity, but we encourage you to have a conversation with your patient regarding opportunities for physical activity and active lifestyles. And then, of course, psychological therapies or psychotherapies. The image there is a painting by Kay Sage, an American surrealist painter, and it's quite haunting, I think. I put that up because psychological therapies, psychotherapies, make us think about what is the origin of the loneliness for a particular person. Is it something that the person has had to deal with throughout their life? Does it relate to early life experiences? We talk about theories around attachment to parental figures, secure attachment or insecure attachments. And I think there's a lot of evidence that people who suffer through life with loneliness have had often difficult early lives. So there's a whole variety of psychotherapies that can be helpful, including CBT, social cognitive therapy, reminiscence therapy, and mindfulness-based stress reduction. And perhaps not surprisingly, there is greater evidence for psychological therapies in reducing loneliness compared to social isolation. So it makes sense that when a person is suffering from loneliness, and there are roots to this, that psychotherapies can help. So, you know, CBT is a particular approach. And again, CBT is good for many conditions. It certainly can be helpful here. This image shows the sort of downward spiral of loneliness through negative thoughts and feelings, which leads to behavior change, negative behavior change, a negative cycle. And the whole idea of CBT is to, of course, to break this cycle through changing the person's long-standing negative thoughts, their automatic thoughts and feelings. Animal-assisted therapies and animal ownership. So there's some evidence in support of this. Not surprisingly, the image on the right comes from the BBC, and it talks about the campaign to end loneliness in the Netherlands. And this is Theo and dog Bikkel, and it's a very interesting article about how through a tragic event in the Netherlands, the discovery of a woman in her home who had died many years earlier, an older woman, that a local politician decided to do something about this. And through his work, a whole national campaign developed with some really excellent processes and ideas. This image, it characterizes a matchmaking website where busy pet owners are paired with older adults who don't have the resources to look after a pet, but want to spend time with a pet. And at the time of this article, there'd been over 4,500 successful matches. And of course, it makes sense. You know, if you have this dog, people are going to start talking to you and saying hi, as opposed to Theo just sitting on the park bench alone. So lots of good lessons here. Leisure skill development and activities. There's also some evidence in support of this, and I think this makes sense. A whole variety of different activities and skills that may help people to become stimulated and potentially to link with other people. So some mentioned here include leisure education, art therapy, bibliotherapy, horticulture and nature-related interventions, and music therapy. So all of these are great. And there's a lot of emphasis now on nature and the benefits of a walk in the forest or in the park. Technology really overlaps with a lot of these interventions. And we all, of course, learned about this during the pandemic and how vitally helpful it can be. It's not the whole answer, but it can certainly make things easier in terms of connecting. I love this image. But at the same time, not all older adults are able to use computers or have the resources. And sensory limitations are a problem, finances. So, technology certainly can help, but it's not the total answer at all. There's a lot of studies on technology, particularly through the pandemic. And as noted earlier, we recommend that we do not use medication unless there's an underlying condition that needs treatment. So why are we saying this? We're saying this because some researchers have actually suggested that there are potential medications that could be used. One of them is called allopregnanolone, which is now actually, it's also brexanolone, it's called, which is a new treatment for postpartum depression. But there are studies, basic research studies showing that there's a reduction associated with loneliness. And so John Cacioppo, who's one of the gurus in the area, was one of the gurus in the area of social isolation and loneliness, proposed that as a potential treatment. But and oxytocin has also been proposed. But right now, no, there's no pharmacological treatment. Like I say, unless you're treating an underlying depression or anxiety disorder or some other condition. The final recommendation is around reassessment. So we strongly suggest that having helped a person and made suggestions, that follow-up is really important. Short-term follow-up. In the guideline document, there are mentions of special populations, including the diversity of older adult populations, Indigenous older adults, residents of long-term care homes, and people living with dementia. No time to talk about that right now, but this is very important, of course. And finally, this is such a big issue. We can think about it at multiple levels in terms of interventions, from the individual to society. We as healthcare and social service providers are somewhere in the middle here trying to help out. But it's clear, I think, that in order to make substantial change, I think that we can make a difference. We can be part of the solution. But I think it needs to be a multi-pronged approach at multiple levels across society. Here are some resources that you can get on our website, including the actual guidelines themselves. And finally, just to say that we're uniquely positioned to make a difference. It's important to recognize the diversity within our populations, including incorporating culture and lived experience, taking an individualized approach with shared decision-making. Targeted screening and a comprehensive assessment are strongly recommended. There are many interventions that can help. Also noting that isolation and loneliness are two unique experiences, often connected, but more research and understanding is needed for both. And that we at CCSMH will continue to work with organizations, groups, and individuals across the country to try to help this problem to reduce social isolation and loneliness. This is a QR code that you can use to connect to our website, subscribe to our newsletter. As we go through the Q&A, there will be a very short pop-up, few questions. We'd really appreciate if you take a few moments to complete those. And if you want to email us, this is a special email that you can use to get to us, socialconnections@ccsmh.ca. Okay, I'm going to stop there, and I'm going to stop sharing the slides.
Great. Thank you. Thank you so much, Dr. Conn. That was a whirlwind of a lot of information, and thank you for getting through the amazing amount of information in the amount of time that we have today. So we're going to be moving into a Q&A session. We have about 10, 12 minutes, which we absolutely know time is not going to be our friend on this because there was some interesting conversation happening in the Q&A already. So what we would like to do is if you have a specific question about the guidelines that you would love to get a response from David, if you could put that into the Q&A. And while you're thinking about that and putting questions in there, just a couple thoughts. If you have a question and we don't get to it, we encourage you to write it down because this will really help inform our future communications, and we may be able to produce a frequently asked question that can really help inform a lot more people if you have something that's on your mind as well. So please don't hesitate to get some questions into the Q&A. As mentioned earlier, while these questions are coming in, this session is being recorded. It will be on our website within the next week. And if you have a specific request of information from CCSMH, we highly encourage you to use the info@socialconnections email, which we've opened up. We're going to be opening up the chat, and some of these links will now be in the chat and available to you. So let's move to some Q&A and see what's on your minds. Right. We have one from Hugh. Have you considered the effect of hard of hearing people who suffer loneliness and isolation? I personally have suffered loneliness all my life, and I'm now 77. The chronic disease of hearing, deafness, severe hearing loss does affect my social work and family life.
Yeah, absolutely. It's a huge issue. And it is remarkable how many people who have hearing problems who don't want to use hearing aids. And they can be very expensive. The latest, modern hearing aids can be thousands of dollars, but there are also much cheaper solutions as well, including pocket talkers that are just a fraction of the cost. There's a kind of a stigma as well for a lot of people about wearing a hearing aid. People, especially men, are often very reluctant. But there's a lot of evidence that if you have hearing loss and it remains uncorrected, it can increase your risk for depression and even for dementia over time. So, everything that can be done to try and help a person to hear as much as is possible using devices, I think is absolutely critical. And that is something we emphasize in the guideline document. So thank you for that question.
Thank you. Let's see, I had my question and then it moved around again. Let's see. There is a rise from Robin. There's a rise in multidisciplinary teams and primary healthcare teams. Do you think the availability of an in-house social worker will help to tackle this issue more efficiently going forward?
Absolutely. And, we talk about social prescribing. So the question is, who should do that? And if you're lucky enough to be part of a team with expertise about the community, social workers are usually the best person on the team who really understand the resources out in the community. And so social work can often be that connector. So, and I think, I think most of us feel that in primary care, multidisciplinary teams, the interdisciplinary teams that can make up a primary care team is the optimal way to go. And unfortunately, there hasn't been enough funding for these teams. And there's still a lot of solo practitioners who try to do everything themselves, which is pretty hard.
Thanks, David. Next we have from Rob. Is there any evidence to suggest that medications, especially medication overload, can have negative impacts on loneliness or social isolation? Have you discussed that in the report?
So the question there, I guess, is around too much medication. And so that's a very interesting one because in working in the field of geriatrics, we often want to de-prescribe as opposed to prescribe. And it's true that often people are receiving more medications than they actually need for various reasons. One of those is something called a prescribing cascade, where somebody is put on a medication, then they develop a side effect, and their side effect is treated with another medication, which produces another side effect, and so on and so on. So deprescribing can be really important, especially around certain types of medications, such as benzodiazepines, which are, tranquilizers, for which people often become addicted, and over-sedated. So medications that over-sedate could certainly cause isolation and lead to people not going out very much. So that's a really interesting question. Thank you.
Thanks, David. There are several questions of raising a lot of interest in the idea of the link worker. So from Renee, there is little or no community program that's readily available for low-income seniors. So while in theory, I love the idea of a link worker, if there's no programming available, where could they connect the client to? And I think we can also share in the chat a link to the Canadian Institute for Social Prescribing as well, I think, as a resource. So that's the question, David, while we also provide a resource in the chat.
Yeah, I think, if you go to CISP, the Canadian Institute of Social Prescribing, and the organizations that make up that group, they have a lot of information about the development of these resources. But you're absolutely right. There's huge variability in what's available from, and often we face the issue of model programs where resources are made available for a short period of time to test out a particular idea or model, and that's beautiful. But then they're not widely available, and sometimes they're not sustainable. So I think your point is well taken. Ultimately, we need more resources. I don't know, Claire, did you want to add anything to that?
Well, the person who asked the question is absolutely right. As you've said, we did try to think a little bit outside of the box and have some recommendations that that don't need programming specifically. So going for walks, getting in nature, feeding birds, that sort of thing that can really help a great deal in just starting to incrementally make progress towards perhaps bigger changes later on. And one of the other questions in here was a little bit about motivation, and that was something we were thinking about there too. Sometimes when you're stuck or feeling stuck, celebrating the very tiniest steps can help you make the next tiny step. So I think that we tried to look at that sort of thing. We are also hoping to look at the policy side of things a little bit moving forward. So again, the access to resources, bridging though between resources that do exist that maybe healthcare practitioners don't know about. And so making sure that communication is happening better. And then similarly looking at access to things like CBT and some of the other questions you guys have mentioned around hearing and that sort of thing, where there's some policy issues in the way as well, and income related issues.
Thanks, Claire. We've got time for, I think, one or two more. And so from Marjorie, were there any specific cultural considerations, I'm assuming taken to incorporate into these guidelines? Any specific cultural considerations?
I think one of the main points we say in the guidelines is that when it comes to equity deserving groups, minority groups that need special consideration, those groups need to be actively engaged and involved in coming up with solutions. So we've prepared a kind of scaffold of interventions and approaches that we think are worth considering. Recognizing, though, that every community is different. I think one thing that's worth mentioning is, of course, is that people often prefer to socialize within their own cultural group. And that's natural. Birds of a feather flock together. And so that needs to be taken into account. On the other hand, there's a lot to be gained through diversity of connections. So it's finding that right balance as well. Claire, anything you wanted to add to that?
Well, like many of these issues, there isn't enough literature on it, and certainly not enough definitive answers. But and much more work needs to happen, both for issues of diversity, but also intersectionality of different diversities that people experience in their lives. So I think we are absolutely calling for more work, more research, but also just more sort of community supports and helping people bridge to what works for them, and who this sort of all that makes up the individual that they are.
Thanks, Claire. Before we go to this next question, we're going to launch the feedback poll. It will be coming onto your screen. It's 4 questions, and we really, really welcome your taking a moment to share with us a little bit about your interest and your feedback on this webinar. So thank you very much. Okay, let's go to, I think we've got room for one more question. I would like to comment, there are some amazing resources that are being shared in the Q&A about different social prescribing initiatives. So in addition to CISP, which is in the chat now, CISP would also have access to some of the resources that are being shared, but there are many, many amazing initiatives that are happening at the provincial level. So to know that there is a great deal of activity that's happening, and encourage you to check into your either national, your provincial, or even maybe your regional networks to see what's happening around social prescribing. There seems like a lot of other countries have national strategies. What are your thoughts on a national strategy around social isolation and loneliness in older adults for Canada?
I think we need a national strategy and multiple national campaigns aimed at different groups. I think we've been lagging in this regard. Some people would argue that it's a very difficult thing to resource, but I think with multiple levels of government, I think this is possible. And I'm really struck by, as I mentioned earlier, by the examples from the Netherlands. It's really about making change at the local level. It's not about, you can have a national campaign, but ultimately the changes have to occur locally, and it's in local groups, organizations, communities coming together, just doing little things. They have one thing in the Netherlands called the chatty checkout, which has, I think, come to a few places in Canada. It's simply when you're in the supermarket, they have one lane for people who actually want to talk to the cashier, and the expectation is it's going to take longer and there's time to chat. It's a little thing, but it can make a big difference to people. So, but when it comes to a national campaign, I think we need it here in Canada to make changes. And I know there's all sorts of groups are coming together now to propose this. And I think CCSMH can be involved in hoping for some policy changes. Claire may want to make a comment about this as well.
I think, I mean, I'm always hesitant about campaigns per se, unless they're done for the right reasons and adequately resourced and using the right people and all that sort of thing. I know that we are committed to trying to do our own sort of campaign, but in terms of getting the guidelines implemented through health and social service people as much as we can, and bringing them to their attention and helping to bridge the social services and healthcare into older adults themselves, and maybe bring back the concept of social connection that perhaps was lost, well, has been being slowly lost for some time now, but that I think people are more aware of and sensitive to after COVID and all of us feeling a little bit of it.
Thanks, Claire. We're coming up to the end of our time, and I would love to actually use a quote from the Q&A from Jennifer to bring us to close. And Jennifer says, "It will take some creative partnerships in recreation and leisure, community groups and government at all levels to assist in overcoming the health challenges that come with this. Every level of society needs to make this a priority. We are all in need of a community to surround us." So I don't think I could have summarized this any better. So thank you, Jennifer, for that inspirational quote. So we've reached the end of our time today, and we thank you so much for joining us. We hope you found it interesting, and you will be able to find a link to the recorded webinar on our website in the week ahead. And we look forward to staying in touch. And if you would like to connect with us directly, either with some questions or some information, then you can reach out to that email, What Social Connections, that will be in the chat once more. So thank you so much, everybody, for joining us. It's been a pleasure, and we look forward to staying in touch. Bye for now.
Bye, everyone.
Bye.